So good morning, everyone. Thumbs up if you can hear me. Excellent. Well, welcome everyone to Cardiology Grand Rounds. It is wonderful to see faces. Hopefully, as the year goes on, we'll see many, many more faces. I'm delighted to introduce David Siskovic this morning. David is a senior research scientist at the New York Academy of Medicine, as well as Professor Emeritus of Epidemiology and Medicine here at the University of Washington. For more than 3 decades, David has been an academic general internist and clinical cardiovascular epidemiologist with a focus on bridging clinical medicine with public health. David has a highly successful track record of research related to chronic disease prevention, health disparities, and healthy aging, with more than 800 peer-reviewed publications, many in high-impact journals, and multiple NIH grants. His research has broadly focused on the epidemiology and prevention of cardiovascular diseases by examining a range of characteristics, including exercise, nutrition, diabetes, renal disease, drug safety, air pollution, genetics, sudden death, you name it, David studied it. At the University of Washington, he founded and co-directed the Cardiovascular Health Research Unit, a research unit with the goal of improving the public's health through research, as well as through training the next generation of research scientists. And while he was at the University of Washington, David led the cardiovascular epidemiology training program. David excels at many things, but perhaps where he truly shines is as a mentor. And it's a testament to his mentorship that many of his trainees have gone on to themselves have successful academic careers. He's received a number of accolades and honors, many of which recognize his outstanding mentorship. He's received teaching and mentorship awards from the AHA, the Robert Wood Johnson Foundation, American College of Physicians. I personally have been very fortunate to have David as a lifelong mentor. In 2014 and 2018, David was listed among the world's most influential scientific minds by Thomson Reuters. He served on the board of scientific counselors for the National Institute of Aging. He's a past chair of the AHA's Council on Epidemiology and Prevention. We're fortunate to have David with us today as the Locke Visiting Scholar. And a big thank you to the Locke Foundation for supporting these visiting scientist activities. Many of us have benefited in numerous ways from the Locke family's generosity, from startup research funds to these visiting professorship exchanges that are really, really important to both our faculty and our trainees. Thank you again for joining us this morning, David. Really looking forward to your talk.
Well, it's a true privilege and honor to be here today to give the Locke Cardiology Grand Rounds. Let's see. We're not moving. Let's see. Is there a reason it's not moving? Let's see. Over there until the everything. Okay, great. Okay, so today I chose this title, Lost in Translation: What Can We Learn from Studies of the Determinants of Sudden Cardiac Arrest in the General Population? As Nana mentioned, my interests are very broad. They all focus on cardiovascular health, and within cardiology and cardiovascular health, a major passion that I've had is around identifying determinants of sudden cardiac arrest, and I'll explain more about that in a minute. But I've also qualified what I'm going to talk about today in terms of determinants of sudden cardiac arrest in the general population. Hopefully as we go through this presentation, you'll pick up on what you think has been lost in translation, what's new, what am I calling attention to that you may or may not have been aware of in your work in the past. Oops. Okay, so before starting, I want to acknowledge some groups and provide some thank yous. First of all, to the Division of Cardiology and to what was called the John Locke computer. When I was in training, and I came here to train in medicine and public health. When I trained in public health, I was training in epidemiology, and I needed to have a mainframe computer to work with to do the analysis of some of the data that I'm going to show you today. And it turned out that the Locke family had given a mainframe computer to the Division of Cardiology. It was one of the few, if maybe even the only mainframe computer in the School of Medicine at the time. And because of a collaboration I had with biostatistics, I was able to get access to the John Locke computer and was able to do an analysis that resulted in some of the work that I'm going to present this morning. So I want to acknowledge the Locke family for their long support of the division and the school and the university. The work I'm going to be presenting initially as the initial part of the presentation goes back 40 years. So we're really talking about sustained contributions to the division that have enabled folks to do research and training that hopefully you will agree is important. And I want to thank them. Secondly, I want to thank the Medic One program and the King County EMS program, specifically Dr. Leonard Cobb, who's a distinguished Emeritus faculty of this division, and Dr. Michael Kopis, who is a distinguished faculty from neurology, the late Dr. Kopis. The two of them were giants or are giants, as well as Dr. Mickey Eisenberg, who was one of the founders of the King County EMS system. And you'll see in a minute why I think I owe substantial gratitude to them and to their programs. I also want to acknowledge all of the paramedics who supported the work that we've done over the years, and also the Medic One Foundation that provided support for the initial work that led to NIH grants, and the NHLBI. I want to thank them for their support of the research that went on for multiple decades. And then finally, I want to thank my colleagues at the University of Washington Cardiovascular Health Research Unit, one of which is Nana, and there are multiple other colleagues without whom this work, my career, the work of many, many people in cardiovascular health at the University of Washington could not have been done. Okay. Can I get rid of this bar at the top? Or does that need to stay there? Yeah, if we could move it, that would be great. Okay, so basically, this slide has sort of three components. Thank you. All the way down. Thank you. Oops. Great. Sorry about the technical problems. Okay, so the first thing is the title, Transformation of Clinical Cardiovascular Epidemiology Over 40 Years, and it says the why. Simon Sinek emphasizes that we should focus on the why if we want to be inspirational and not the how or the what. So I'm going to talk about how and what as we go through the presentation, but the why is basically at the bottom of the slide, which is sort of, as clinicians and as cardiologists, most of you focus on three clinical questions. What's the diagnosis? What's the prognosis? And what's the treatment? If you're interested in prevention, then you tend to focus on the fourth question, which is what's the etiology? What are the causes of the diseases or the health status that you're observing? So what I'm describing at the bottom here is sort of how clinical cardiovascular epidemiology has transformed over 4 decades. And it was always interested in etiology using epidemiology and prevention. And the goal of the epidemiology was to be able to do a better job at prevention. And when I started, I was in the middle here. I was on the blue boxes, looking at physical activity, dietary intake, and drug safety. Over the years, the field of clinical cardiovascular epidemiology moved to the left in terms of looking at molecular mechanisms, looking at genetic and epigenetic determinants, and more recently looking at developmental origins, that is early life origins of adult disease. And even more recently, there's been a focus, as many of you know, on population health. What's happening at the population level? How can we improve the health of the public? And there's an interest in policy and practice. And then there's also an interest in something called solution-oriented research, which I may have a chance to talk about briefly. Okay, now that we move the bar, I don't see the, Greg, I'm sorry. Okay, great, thank you. Okay, so this is a technical, so bear with me, I'm gonna provide some introductory comments and then we're gonna get into sort of what I think we know, what I think has been lost, what I think we don't know, and so on and so forth. First of all, we have to define sudden cardiac arrest, and I'm gonna acknowledge Nana's contribution to this definition. So sudden cardiac arrest is operationalized as a sudden pulseless condition in a clinically stable patient and in the absence of a non-cardiac condition as the cause of cardiac arrest. You know, for many years, people say, well, everybody dies and everybody dies a cardiac death, and everybody, you know, when their death occurred, it tends to occur, you know, instantaneously. But it doesn't occur in all people sort of as a sudden pulseless condition in a stable patient and in the absence of a non-cardiac condition as the cause of cardiac arrest. So one of the arguments I'm going to make is that it's important and reasonable to look at sudden cardiac death as an outcome. Okay, another reason it's important is because it accounts for about 10% of total mortality. And that really hasn't changed over the years. And it accounts for about 40% of coronary heart disease mortality. So if you have coronary heart disease, you either die an arrhythmic death or death from heart failure. In heart failure, you gradually lose your pulse. In cardiac arrest, you suddenly lose your pulse. Larry Hinkle in the 1980s published papers describing this so that we could differentiate sudden cardiac arrest from other forms of death due to heart disease. In sudden cardiac arrest, as most of you know, there are multiple different forms of structural heart disease that can contribute to it. But from our perspective, as people interested in what's going on in the population, the most common form of structural heart disease is coronary heart disease in terms of sudden cardiac death patients. And it typically is there and accounts for maybe 85% of the out-of-hospital cardiac arrest in the community. Also, enabling us to study this as an outcome, if you will, is the fact that ventricular fibrillation is the most common initial cardiac arrhythmia in sudden cardiac arrest, particularly if an event is witnessed, and it's an even larger proportion of the events. If it's witnessed and unwitnessed events, it tends to be about 2/3 of events if they're attended by paramedics. And as you know, survival from out-of-hospital cardiac arrest depends on multiple factors that are related to EMS, as well as patient characteristics such as their initial rhythm. So if they're in VF, they have a much better chance of being resuscitated successfully. So this is where this story really started. People sometimes ask me, well, David, how did you pick the questions that you looked at? And initially what I did was I was in the middle of that 40-year transformation, and I was interested in questions that were of interest to clinicians and the public. I was a clinical epidemiologist, so I wanted to pick questions that were of interest to both groups. So I picked, you know, at the time in the 1970s, there was controversy about whether physical activity or vigorous exercise in particular increased the risk of sudden death, decreased the risk of sudden death, or did both. And, you know, whether the occurrence of a life-threatening arrhythmia during exercise was a coincidence, did people just happen to die during exercise, or was the actual bout of exercise related to the occurrence of the event in time in terms of potentially triggering it? And we were very fortunate because of Len Cobb and Mike Kopis and Mickey Eisenberg and the paramedics in Seattle to be able to use and King County to be able to use their EMS system as a surveillance system for out-of-hospital cardiac arrest, where the initial rhythm was detected on all of the patients basically who were attended by these paramedics. And we used that, and we developed a population-based case control study of individuals who experienced cardiac arrest as their initial clinical event that has no prior history of heart disease and also no form of comorbidity that could have contributed to the sudden cardiac death, like renal disease, liver disease, lung disease, problems with stroke, overdose, suicide, trauma, et cetera, et cetera. And what we found in this study was initially we were looking at the overall impact of exercise. What we found was that overall people who engaged in vigorous exercise habitually had a lower risk of sudden death or primary cardiac arrest, we called it at the time, than people who didn't engage in vigorous exercise. And it turned out that if you engaged in 20 minutes a day to 20 minutes a week to 20 minutes a day, you basically had half the risk of those who engaged in no vigorous exercise. And if you engaged in more than that in terms of time in vigorous exercise, there was no additional benefit. So it looked like some vigorous activity was better than none, but that more wasn't necessarily better than less. And then what we did was using the same data set, it turned out that we had asked about the time spent in vigorous exercise, as well as the time spent not in vigorous exercise. So we were actually able to look at whether or not the rates per unit time were higher during exercise than at other times. And we were able to look at it in the context of habitual activity. And what we found was that during exercise, risk was increased compared to other times. But there was an interaction with habitual activity level, so that the more active you were habitually, the lower the increase in risk during exercise compared to not during exercise. And what it turned out was there were risks and benefits, and the benefits outweighed the risks, as we showed in that first study. And so this was actually of interest because, again, there were different perspectives within medicine and research and public health as to whether exercise was a good thing or a bad thing when it came to cardiac arrest. Unfortunately, the work we did on incidents during vigorous exercise was replicated. You can see Christine Albert, who's now the head of cardiology at UCLA, and previously was at Brigham and Women's Hospital. Christine, who's a cardiologist, electrophysiologist, epidemiologist, was actually able to replicate our study in terms of triggers 18 years after we did it here in Seattle. And then she subsequently did it in women as well. So that was sort of our foray into looking at a health behavior like exercise. Then we said, well, we looked at exercise, maybe we should look at diet. And it turned out that in the mid-1980s, 1985, Don Kromholt from Holland published a paper in the New England Journal from the Zutphen study that suggested eating one fatty fish meal a week was associated with a 50% lower risk of coronary heart disease mortality. And so I had come back to the University of Washington, and I took advantage of the fact that there was a Howard Hughes professor of biochemistry named John Glomset, who had written an editorial in the New England Journal on the same issue about omega-3 fatty acids and cardiovascular disease. So I went to see him, and I described the study I was thinking of doing and asked him if he thought it was worthwhile. And he said, absolutely. So we went ahead and did this study with Rosen Lamette and others from the CHRU, looking at dietary intake and cell membrane levels of long-chain N3 fatty acids from fatty fish and the risk of primary cardiac arrest. And so we had two measures. We had a dietary measure, we had a circulating fatty acid measure using red cell membranes as a biomarker of dietary intake. And what we found was that dietary intake of fatty fish and the omega-3 fatty acids in it and cell membrane levels were both associated with a profound lower risk of primary cardiac arrest or sudden cardiac arrest. And that basically was, again, very consistent with what Kromholt had found. And then what happened was subsequently, Christine Albert demonstrated again that fish consumption was inversely related to risk of sudden cardiac death, and that blood levels of these fatty acids were also inversely related. Turned out the inverse relationship with fish consumption was nonlinear, which basically means that some intake of these fatty acids was associated with a lower risk, but more intake wasn't. And again, it sort of suggested the same thing, that very low levels of intake might make a difference. And then when you looked at how diet was related to the levels of the red cell membrane fatty acids, there was a plateauing of the effect. So, you could increase the levels in the cells by increasing diet up to a point, and then it plateaued. So this was of interest, but it actually became of more interest because when the GC Prevenzione study was published, which was a randomized controlled trial of post-MI patients where they used omega-3 fatty acids at 1,000 milligrams, and they also looked at vitamin D in a factorial design, they were shocked that the vitamin E, the antioxidant, had no impact on recurrent events and death, whereas the omega-3 fatty acids was associated with a lower risk of total mortality due to a lower risk of CHD mortality, due to a lower risk of what looked like sudden death. And so I got a trip to Italy to help them figure out whether this could be real or not. So it's an example of where observational research may have sort of confirmed, if you will, in advance, the results of a very large clinical trial. And as you know, there's a lot of controversy since then about omega-3 fatty acids and heart disease, and most of you probably are aware of this. But one of the things I'm gonna let people know, and it's actually the second study, the fish consumption and risk of sudden cardiac arrest study from Christine Albert, because she was looking at a cohort. She was looking at one of the Harvard cohorts of physicians. She was able to not only look at sudden death, but she was able to look at non-fatal MI. And what she found was that fish intake was related to sudden death, but it was not related to non-fatal MI in her cohort, suggesting that the same factor might have a different relationship with different outcomes. Now, keep in mind, most clinical trials will combine multiple outcomes, non-fatal MI, fatal MI, sudden death, et cetera, et cetera. And this observational data sort of raises a question, is that a good idea? Is that a good idea? And are you missing something when you combine multiple endpoints? Okay, so then I was interested, I mentioned clinical questions that came up. One of them was, there was a famous study called the multiple risk factor intervention trial. And it basically was going to be the study that showed that altering risk factors lowered the risk of CHD mortality. And that was going to give me a reason to pursue a career as what one of my fellow residents here at the University of Washington called me a risk factor doctor. So this was going to basically reinforce my interest in prevention and be a risk factor doctor. Well, it turned out in the Murfitt or Mr. Fit study, there was the less than expected impact of multiple risk factor interventions on CHD mortality. This was in the 1970s and early 80s. And it turned out that they had started with 50 milligrams of either chlorthalidone or thiazide. They had gone to 100 milligrams of chlorthalidone or thiazide, and they even considered going to 200 milligrams of chlorthalidone or thiazide because they weren't seeing the expected reduction in CHD mortality. And at the end of the study, they raised the hypothesis, well, maybe there was an adverse effect of the thiazides, chlorthalidone or thiazide, on CHD mortality through hypokalemia, hypomagnesemia, or some impact which may or may not have interacted with ECG features to increase the risk of death, which basically, if what we observe is the overall effect of an intervention, maybe the risks in that case mitigated some of the benefit. So we did a large study in what was then Group Health Cooperative in Puget Sound. It's now Kaiser Northwest. And the way we were able to do this, again, thanks to Len Cobb, Mickey Eisenberg, Mike Kopis, we were able to link EMS data with group health enrollment data and death data with their computerized pharmacy database at the time, which was way ahead of its time because it went back to 1977. And we were able to look observationally at a safety question. Is the dose of diuretic therapy or the type of diuretic therapy related to the risk of sudden cardiac arrest? And it turned out that both the dose and the type were related. If you were on a higher dose thiazide, you were at a higher risk than if you were on a lower dose thiazide. And if you were on, even if on a lower dose thiazide, if you had a potassium magnesium sparing agent in addition, you had an even lower risk. Turned out when I presented this data first at an AHA meeting, one of the senior investigators from Murfitt came up to me and said, David, we were always worried about this and you've actually shown it with data. So it was sort of after a clinical trial using observational data to help interpret if you will. Now, one of the reasons this made sense was because the old trials of hypertension therapy all used moderate and high dose, whereas the newer trials had already gone to using low dose, 25 milligrams, 12.5 milligrams, and so on. The newer trials had shown benefit in terms of mortality from coronary heart disease. The older trials had not shown benefit. So this was observational data in between the old trials and the new trials that may have helped with the interpretation. Now, I want to mention something else. We frequently think of, well, the risk factors for sudden death are the same as the risk factors for coronary disease. I mentioned Christine's work on fish, suggesting maybe not all the time, but clearly a lot of the risk factors are the same for sudden cardiac arrest and for non-fatal MI, because they're both related to atherosclerosis. And so risk factors related to atherosclerosis, coronary artery disease are likely to be related to both outcomes. And so, you know, that actually has a message in it, and that is that if we're gonna focus on some of these risk factors, we may have an opportunity to impact multiple outcomes, not just one, or that treatment of the risk factors might have multiple effects, and those multiple effects may impact different outcomes in slightly different ways. So this is just a list of some of them. I'm going to talk a little bit more about race, ethnicity, and about diabetes. So with regard to race, ethnicity, as most of you know, there are major differences in incident rates of sudden death comparing blacks to whites. And this was the sort of a summary of the data from a study that was done in an atherosclerosis risk and community study that looked at sudden death risk by race and gender. And Nana is one of the co-authors of this paper. And Nana is one of the people who made this analysis possible because she organized a group of cardiologists to review all of the coronary heart disease deaths in ERIC and in other studies, as you'll see. And so basically what they found was that the cumulative risk, if you will, of sudden cardiac arrest by race, gender in ERIC, cumulative up to age 85, was about 9.6% cumulative risk among black males. It was about 6.6 among black females. It was 6.5 among white males. So white males and black females had essentially the same risk, but white females had a risk of 2.3%, and the difference in the women accounted, together with the difference in the men, accounted for the race ethnicity differences related to sudden death. So overall, black race was associated with over twofold increased risk of sudden death compared to whites. So then they asked the question, well, what is the role of traditional risk factors in accounting for this disparity? And it turned out that they looked at a bunch of traditional risk factors, did a very good job, and it turned out it accounted for about 65% of the difference in blacks and whites in terms of sudden cardiac arrest. So traditional risk factors seem to be important, even though traditional risk factors were related to risk among blacks and among whites. And for most of the risk factors, they were related in a similar way. The only risk factor where they were a little different was hypertension. Hypertension had a much stronger impact on sudden death in blacks than it had in whites, although it was important in both race ethnicities. So one of the things they pointed out was that probably one of the things that's contributing here is the fact that blacks have a much higher prevalence of these risk factors, particularly hypertension, particularly diabetes, and particularly some of the socioeconomic issues, which were major contributors to the disparities in this study. And those include income, low income, poverty, and low education. So this is a study that suggests that these potential determinants of sudden cardiac arrest, may impact the overall rates in blacks and whites and account for the disparities and the inequities. And they point out that maybe things like access to care, quality of care, and potentially differences in underlying structural heart disease. I've recently bemoaned the fact that we don't really do a lot of autopsy studies these days and rely on imaging, even though imaging is hugely important. It may not be as rich a data source as autopsy. In any case, the question is whether the underlying structural heart disease in blacks is the same as underlying structural heart disease in whites, and whether in women and men it differs within race ethnicity. So these are sort of important issues to address if our overall goal is not only to understand etiology, but also to be able to do better in terms of prevention. Now, in terms of diabetes, we all know that coronary heart disease and heart failure are common in diabetes, and that they likely contribute to the risk of sudden cardiac death. But what may be less known commonly is that there's evidence from studies that we've done that both microvascular disease and autonomic dysfunction contribute to the risk of sudden death in the setting of diabetes. And that's something that, I don't think any of us have really focused on the way we might. The other thing is the corrected QT interval. We had several papers that suggested that if you were in the upper quartile of the heart rate corrected QT interval and you had diabetes, you had a threefold increased risk of sudden death compared to if you were in the lower three quartiles. And then finally, I put drug therapies for hyperglycemia here because the newer drug therapies, whether we're talking about sodium glucose cotransporter type A antagonists, or we're talking about GAP1 agonists, both of them seem to have an impact on cardiovascular disease as well as renal disease, and they very well change the game as it relates to diabetes and cardiorenal disease. So one of the things I wanted to point out, a lot of us would like to be able to do what I would consider an accurate risk assessment or clinical prediction. And so one of our colleagues, again with Nana, did a paper that focuses on clinical risk prediction of sudden death using data from two large cohorts, ERIC and CHS. And he included 12 variables, demographic, clinical, laboratory, ECG factors. And what he concluded was that this model, which was, they sought to target prediction of risk of sudden death, that it was only slightly better than a model that was developed in 2013 to predict non-fatal MI, fatal coronary heart disease, non-fatal and fatal stroke. So, prediction was pretty tough. You could discriminate and you could array people across 10 deciles with a range of risk, but prediction was a problem. And actually that arraying people across risk, that was done in the 1980s by Bill Cannell from Framingham. And it was pretty much the same kind of a finding. So nothing had really changed there. One of the things that was interesting is that many of us thought that a low ejection fraction would be an important player in prediction of risk. Well, it turned out in the general population, and I'm not talking about clinical populations here, I'm talking about the general population, ejection fractions less than 50% are very uncommon. Only 1.1% of the people in ERIC and CHS had an LVEF of less than 50 at baseline. And therefore, LVEF less than 50 didn't improve prediction. So it's something that many of us have thought about, but the data just aren't there to suggest that it's going to make a difference. So challenges to clinical prediction include the following. One, in the general population, these events are relatively rare, so there's a low incidence over the next 5 years or the next 10 years. This paper on prediction looked at the risk over the next 10 years. There are modest relative risk estimates. Typically 2 to 3 is a high relative risk, 1.5 or so is a modest increase, but both are not at a level where we can really use the data clinically to say you're going to have an event and you're not. Also, we have the issue of interactions potentially between coronary, myocardial, and electrical factors. And many of stuff that we're looking at is related to one or the other, but not to all three. Interestingly, he included in the prediction model the directed QT, for example. He looked at whether adding variables like high sensitivity troponin or NT-proBNP would make a difference, and neither of them made a difference in prediction. So we still have a ways to go. And there's another factor, maybe triggers that are transient make it harder to predict who's going to have an event. You have the role of genetic variation, of lifestyle, as I pointed out, and of treatments. And then you have the issue of risk development across the lifespan. So one of the things you'll see is that with the opportunity to look at variation in genes, we have the opportunity to look at variation in factors that may impact risk factors throughout the lifespan and not just at midlife or later in life. Okay, so getting back to transformation of clinical cardiology, I'm now going to move on to molecular mechanisms and then genetics. And I'll try to, I'm not sure I have the time. I think I'm doing okay. Okay, so in terms of molecular factors, I want to point out some incredibly important work that you may not have been following, but I think you might want to keep your eyes open for it. And it's work that is led by Rosen Lamette here at the University of Washington. She leads the work nationally. She leads the work globally. She's a PhD in lipid membrane biochemist who incidentally worked with John Glomstadt, who was a Howard Hughes professor I mentioned at the early part of this talk. And she's also trained in epidemiology, and she's an important investigator at the Cardiovascular Research Unit and was recently promoted to research professor of medicine here at the UW. So Rosen had worked on the N3 fatty acid story, and we said, well, why don't we look at trans fatty acids, alpha-linolenic acid, and linoleic acid, and fatty acids that reflect dietary fat intake. Basically, 15-0 and 17-0, and some other fatty acids tend to reflect dairy dietary fat intake. And so she's published papers on this, papers from our own studies, paper from the cohort studies, papers that use multiple measurements within a cohort studies, papers that use measurements across 16 to 20 cohort studies, and so on and so forth. So this is a small, it used to be a small cottage industry. It's becoming a huge industry to look at circulating fatty acids, whether they're in plasma phospholipids, whether they're in red cells, and whether in the cholesterol esters or whatever, and their relationship to cardiometabolic health. And it's been a fascinating story, and it's really enhanced the whole sense of, you know, what's the role of dietary fat, what's the role of metabolism. You know, we used to think of dietary fat in terms of polyunsaturated fat, monounsaturated fat, and saturated fat. No more. We don't think about that. We think about specific fatty acids, we think about specific foods, we think about food patterns. Okay, in terms of metabolism, she's looked at things like de novo lipogenesis, long-chain saturated fatty acids, long-chain monounsaturated fatty acids. Some of these relate to eating peanut butter. Some of these relate to switching from a high-fat diet to a low-fat diet, where you end up increasing intake of carbohydrate. And all of these things tend to have been shown now to have impacts on cardiometabolic health, thanks to Rosen and others. Rosen has also led the work on ceramides and sphingomyelins, which are also related to fatty acids. And with Nana has led work on EATs and DEETs, eicosanoids, which are also related to fatty acids. So here at the University of Washington, you have a group of investigators who are doing really the best work in the world in this important area of molecular epidemiology and so on and so forth. And then finally, in terms of metabolism, oh, I just said that. Yeah. Oh, I'm going the wrong way. That's the problem. You can see that I'm technologically challenged. Okay, now I'm going to transition to what I'm going to talk about in terms of genetics. But before talking about genetics, I want to set the stage, put it in context, okay? So with my colleagues, our colleagues Yechiel Friedlander from Hebrew University in Jerusalem, we basically decided to look at family history comprehensively in our work on sudden death. And so we asked folks about their family history in parents, which is usual, but we also asked about family histories in siblings, and we also asked about the age at which a family member might have had an MI, and the age at which a family member might have had sudden death. So you can think about all of these different, you know, sort of characteristics that we're able to assess just with questionnaire data. And what we did was we found, first of all, that a family history of MI and a family history of sudden death, both were associated with the risk of sudden death in an individual when considered simultaneously, suggesting that they might be reflecting a different set of factors, right? In the past, what we had done, we had combined family history of MI and sudden death, but looking at them separately, they both were important, sort of raising some interesting questions. The other thing we did was we looked, okay, parental history, you know, history in first-degree relatives, which include siblings, and found pretty much similar findings, whether we looked at parents or parents and siblings. But when we looked at the issue of either the age at which the sudden death occurred, or the age at which the family history of MI or family history of sudden death occurred, we found even more interesting findings. It turned out that a family history of sudden death was related to sudden death in a case before age 65, but not after age 65. So it's related really to early onset, if you will, sudden death, maybe pointing to genetics. The other thing that we found was the family history of MI was related to sudden death, whether you were young or not, whether you were under 65 or over 65, maybe because what it's reflecting is atherosclerosis rather than some of the other mechanisms that might contribute to sudden death related to electrogenesis and propagation or related to myocardial damage. So this was actually a paper that helped provide a background for a workshop at NIH on genetics of sudden death around 2000, so over 20 years ago. And that workshop wanted to stimulate work on genetics of sudden death, and it laid out a set of possibilities as to what could be accounting for the genetic, what genetically could be accounting for familial aggregation of sudden death. Okay, keep in mind that familial aggregation is more than genes, it's also shared environment. Okay, so what Nana did was she did a large GWAS of sudden death using the cases from Seattle from her cardiac risk blood study and other studies and non-cases, and it was on 4,000 cases and 26,000 controls, and basically found with a genome-wide association study the common genetic variation across the genome in candidate arrhythmia genes was not associated with sudden death. And the GWAS was essentially a negative GWAS. And that was interesting because this study, while it's relatively small compared to other GWASs that can be done today or have been done today and reported, it's unlikely that we missed any genetic variant that was associated with more than a 1.3-fold increase in risk. So, you know, what we're looking for is really large effects, and we didn't see it. But that wasn't the whole story, because Nana evaluated genetic architecture comprehensively. And actually, the first author of this paper is a former fellow in cardiology here who worked with Nana. Anyway, what she did within this study as well is do a multivariate genetic risk score for known traits that were thought to be associated with sudden death and might be causal. And she used this because she was interested in Mendelian randomization. I was interested in the extent to which it informed the genetic architecture of sudden death. And what happened was she found that genetic risk scores for coronary heart disease, for blood pressure, for lipids, for diabetes, for BMI, for height, for electrical instability traits such as the QT interval and atrial fib were all associated with sudden cardiac death. And these characteristics also seem to be causally related, taking into account the genetics. So this is actually really important because it's suggesting that a good chunk of the familial aggregation that may be genetically determined is related to the genetics of atherosclerosis or the genetics of risk factors. And so, you know, it's important because you might have thought, and NIH thought, that what we were going to find was that it was the ion channelopathy genes that were important, or the cardiomyopathy genes that were important. And in terms of the general population, I want to emphasize, we're talking about the general population. We're not talking about families with multiple affected individuals that are at high risk, you know, in terms of some of these other mechanisms, ion channelopathies, cardiomyopathies, et cetera, et cetera. But in the general population, it's the variants that are related to, you know, what's common in the population: atherosclerotic coronary disease, blood pressure, lipids, diabetes, et cetera. And I think this was an incredibly important finding because I was at that workshop 20 years ago. And I thought that this paper actually addressed an important question from that workshop that hadn't been addressed. So then there were other papers in the genetic area. One was a case control study looking at exome sequencing rather than whole genome sequencing. And it basically focused on 49 genes related to coronary artery disease, cardiomyopathy, inherited arrhythmia syndromes. And what they found was that in this case control study was that 2.5% of the cases that experienced sudden death had variants in one or more of these 49 genes that were potentially or likely to be pathologic, and that none of the controls that were examined had variants that were thought to be pathologic. They then took that finding and went to a large cohort study, and they found that rare variants in the same genes were present in 1% of the adult population from the general population free of cardiovascular disease. And that these variants, these rare variants, if you will, in exomes, conferred a threefold increase in the risk of cardiovascular death over the next 14 years. So this is a different approach to genetics. It's a different study design and so on and so forth. But it addresses an important question and has implications. And then finally, using whole genome sequencing now, and this is data from TopMed, which is coordinated here at the University of Washington, Bruce Posady, Ken Rice, others, Nana and others are involved in this. In TopMed, basically, rare coding variants were associated with ECG intervals and identified monogenetic arrhythmia susceptibility genes at the population level. So, genes are contributing. It's just that in many cases, some of these genes are rare. And so, for example, to be more specific, rare variants in KCNQ1 and KCNH2, which were present in 0.2% of the folks who were in this whole genome sequencing study. And it was, I think, if I remember correctly, it may have been something like 30 or 50,000 people. It was a very large study. They were associated with a 23-fold increase in risk of having a marked QT interval prolongation. However, 70% of the carriers of these variants had normal ECG intervals. You might want to think about that and think about what it means. You do whole genome sequencing to identify these variants. The variants are associated with the QT interval and an increased risk of a high QT interval, but most of the people who carry these variants are going to have normal ECGs. So it has issues in both directions about who do you test and what are you going to find and what does it mean, and so on and so forth. So this is sort of where I come out and say the identification of rare genetic variants through either whole genome or whole exome sequencing is unlikely to reduce the incidence of sudden cardiac arrest in the community, given incomplete penetrance and the low frequencies of rare variants and the low frequency, if you will, of sudden death over a 10-year period in a general population. So what's next? Well, precision medicine is more than genomics and epigenetics. It's also proteomics, metabolomics, and these are important tools that are being used at the Cardiovascular Health Research Unit and by others, and they're likely to identify clinically important subphenotypes, which is something that needs to be done, as well as identify potential targets for novel designer therapeutics. So this work, while it may not improve clinical risk assessment or risk prediction in the general population, still is incredibly important in terms of understanding the biology, the mechanisms, and so on and so forth. So we sort of started in the middle. We went to the left, where the focus is more on etiology and less on prevention. I sort of felt as we moved in that direction, we were looking at smaller and smaller exposures with that might be of interest to medicine and to pharmacology, and biology, but less of interest in terms of population health, which is on the right. So, what about population health? The AHA is a fantastic organization. If you haven't been familiar with it or involved in it, it has basic clinical and population science. They work together, and so it's really one of the few organizations I know that addresses basic clinical and population science. And in 2010, they decided that they were going to focus on cardiovascular health in addition to diagnosis and treatment. And they came up with Life Simple Sevens, which included 4 health behaviors, 3 health factors. The 4 health behaviors were physical activity, diet, BMI, and smoking. And the 3 factors were total cholesterol, blood pressure, and fasting blood glucose. And what they did was they used data on these 7 factors to basically define each individual as either being at poor, intermediate, or ideal health based on the factor and based on an overall score. And unfortunately, the use of the word poor, after the fact, they realized that that might be a label that would not be a good way to influence health behavior. And so they thought maybe we should change that. And they also thought that putting people in these 3 buckets as opposed to having something more continuous might not be helpful. And they also realized there were changes in what was known about diet or what was known about cholesterol, glucose, and so on and so forth. So then what happened was in 2022, Donald Lloyd-Jones, as a recent president of the HA and one of the authors of the 2010 cardiovascular health construct, came out with a new or revised, if you will, cardiovascular health construct, which now is called Life's Essential 8s. And it basically includes the Life Simple Sevens, but it also adds sleep. With the thought that sleep is important not only in terms of influencing other risk of the other 7 factors, but also in and of itself. And so sleep is now considered one of the important aspects of cardiovascular health. They also modified the metrics for cholesterol, so they now focus on non-HDL cholesterol, which can be measured in the non-fasting state rather than total cholesterol. Glucose, they included not just fasting glucose, but hemoglobin A1C. Smoking, they basically changed it to nicotine and included e-cigarettes and vaping, as well as combustible tobacco. And they changed the scoring, so it wasn't poor, intermediate, ideal. They changed it to 0 to 100, and they basically, you can sort of go from green to yellow to red, if you will, in terms of using something like a odometer, and so on and so forth. And importantly, in this report, which I would suggest to all of you take a look at it, because it's meant not just to impact people in public health, but it's also meant to impact clinical practice. And as cardiologists, I think this is something that is important, and particularly if you believe anything that I said before about the risk factors, the genetic determinants of sudden death being related to genetic determinants of risk factors, or the role of risk factors in accounting for health disparities. If for whatever reason you want to pick, this is something that you should be familiar with. In addition, they acknowledge that social determinants of health and psychological stressors are important, but what they pointed out was while they consider them foundational factors, they didn't really have great metrics and how to combine different components, let's say, of social determinants of health. So they have not included it yet in the CVD health construct, but they've said we need to attend to social determinants of health. We need to attend to psychological stressors. So in terms of environmental context of sudden death, these are some of the things that we've thought about and looked at: healthy and unhealthy food retail, safe and complete streets. Complete streets basically mean you also have bike lanes, green space, which enables you to engage in physical activity, may decrease pollution, et cetera, air pollution, and distance from roadway, because work by Joel Kaufman and others here at the University of Washington suggests that if you live within 100 meters of a busy road with a lot of diesel exhaust, it impacts your blood pressure, it impacts your cardiovascular risk. Neighborhood deprivation, whether it's poverty or low education, or whether it's unemployment, or whether it's housing, these are all things that may be important. And then access to healthcare facilities and access to care, which continues to be an issue here in the United States. So what are some of the lessons that we've learned? I think that exercise and dietary intake in terms of prevention are not going to, shouldn't go away. We just need to be more specific and clarify what the messaging should be and to whom and when and so on and so forth. The fact that there are multiple mechanisms among diabetic patients, I think, sort of focusing on coronary atherosclerosis is critically important. But if you only focus on coronary heart disease, coronary artery disease, you may miss important issues with regard to the myocardium, whether it's small areas of microfibrosis, whether it's autonomic input, et cetera, et cetera. So give some thought to that. And somebody should figure out whether the QT interval is worth looking at in diabetic patients. Genetic architecture, we talk about determinants of racial disparities, we talk about, and promotion. I just have one more slide, which is basically, I think it's one more. Whoops, it went the wrong way. Sorry. Yeah. So this is basically, so these are just what we talked about. But this is what I want to end with, is that I think that we do need to focus on primordial prevention, which means prevention of risk factor development. That's something for internists, general internists, family doctors, and pediatricians to work on. We need to focus on secondary prevention in terms of, given a risk factor, how can we prevent events? And that's where, like, the newer drugs for diabetes, there's really no reason that I can see for not moving to those as quickly as possible. The third thing is considering that everything we do has benefits and it may have risks. And if we want to maximize the benefits, we need to minimize the risks. The issue of out-of-hospital cardiac resuscitation is important, but I think that's when all else fails myself. It's not going to have a huge impact given the limitations. And then context, health and place is also important. And Nana, I'm finished. Thank you.
I'm just turning on my mic right now so folks in Zoom land can hear. David, that was fabulous. I wanted to give you extra time because I know we started late because of audiovisual difficulties. If folks can put their questions in question and answer, we'll just take a couple because I know we're already going over time and we have a whole bunch of questions here. I saw Farid's hand first.
Fantastic. So just to emphasize, I think one of your points, from a health policy, you think still going after division like coronary disease risk factors is where it's worth most effort. Is that correct? Did I understand that correctly?
Yeah, so the paper that deals with clinical prediction said there was that the prediction model for sudden death is slightly better in terms of discrimination than the former. You have extensive information on diet because in the 2021 they dealt with 5 dietary factors. Things like nuts, things like whole grains, things like fruits and vegetables, things like fish, and so on. This one has a new set of recommendations with regard to DASH or with regard to a modified Mediterranean diet for Americans, and so on and so forth. So we've moved more away from nutrients to foods, to food patterns, and so on and so forth. There's a long way to go. And in terms of adherence, diet was the worst thing in terms of adherence in the public, particularly in marginalized populations where the prevalence of an ideal diet might have been 1%. So there's a lot of room for improvement. And that's where I didn't get to talk about it, and I won't spend that much time on it, but the idea of doing solution-oriented research exactly relates to your question of diet. We need to do solution-oriented research that quickly tells us what works, where, when, how, and what the impact is.
David, I have my computer
Sure.
here because you closed yours and the Zoom people can't hear you.
Oh, I'm
So
sorry. I'm so sorry.
we have a rough.
statement about a third of the way through that the disparities or the discrepancies between risk between ethnicity or race, 65% of it could be accounted for by traditional risk factors. And I'm just acting as sort of an epidemiologist who does these type of studies. There are also other factors I would assume about factors like hypertension is not a binary sort of risk, right? Like how do you factor in, you know, effectiveness of control adherence? Like maybe it's more, could it be more than 65%? Could it account for most of the risk, or do your studies address the other environmental factors that go into those risk factors?
No, you're absolutely right. Each one of those factors is complicated, right? Hypertension is complicated. So even though GWAS now has identified 500 variants that account for a 10 millimeter of mercury difference in blood pressure and a major difference in the risk of hypertension using various cut points, it's still, there are other factors involved. So that's where you get into things like health in place, you get into what you said, medical care or access to care or quality of care, and so on and so forth. So really, there are very few data sets that have everything. And then the other thing is a lot of our data sets start in midlife or later. And these things may be influenced by early life events or the life events of the mother or the genetics and epigenetics of the father. I'm actually a believer in epigenetic transmission, you know, across generations. And so it may be that exposures, the context of the environmental exposures of mothers and fathers today will impact their offspring's offspring. And, you know, it just may be really challenging. So dealing with something like poverty, you know, can we wait? No. Is it going to take time? Yes. Is it going to be important? Yes. Does it impact multiple factors along the way, not just one factor? Absolutely.
And Rob, just the clarification, 65% wasn't for traditional risk factors. It was for the risk factors in that study. Some of the most important risk factors included SES education. So not just heart disease and hypertension.
Yeah, and that's also like SES and income based on an individual, but then you also have the SES of their neighborhood, which also impacts access to parks and violence and so on and so forth. Yeah.
And one last question.
Yeah, I just want to say I appreciate your attention to primordial prevention, because while Life Simple 7 is important to recognize individual contribution, I feel like if we focus on that too much, it tends to put too much, we can tend to put excessive blame on the patient's behavior for the health status. So I think that attention to primordial prevention, what we can do from the top-down level as a society to improve the health of our society is really important. So thank you.
Yeah, I mean, the point you raise in terms of should we be emphasizing health behaviors or should we be emphasizing sort of societal or contextual factors, environmental factors? I think my own point of view is we need to do both. That's what they came down on. When they said social determinants of health was foundational, they're acknowledging that these factors contribute. They just don't know yet which ones are easily measured and you know, we have specific interventions for them that make a difference and so on. But I think you're absolutely right. It's not, that's where we get away from saying poor, you know, to using a different kind of metric to look at inter-individual and intra-individual change over time. So I agree with you. I agree with you, you fully. And any one of these things is incredibly complicated. So thank you.
On that note, thank you very much, David, for coming back. And thank you to our Zoom audience. Bye-bye.